This is August 28th. Today we're doing our webinar presentation on eating disorders and suicide. Uh, for people who have any questions, please feel free to put them in the chat. I want to start out with a brief comment about this. I want to thank everyone for being here today. As I said, we have more than 2,200 people register for this. This is an incredibly important community that we are building around eating disorders. And today's topic of eating disorders and suicide, although a darker topic, is something that we very much need to discuss. And people who know me know I like to use quotes. So I will start out basically by just saying one of my favorites, and it pertains to suicide, is the Helen Keller quote. Though there is much suffering in the world, there is much overcoming it. I want people to know that eating disorders, behavioral health conditions in general, can feel isolating. Certainly, that is one of the principal things we see as mental health professionals, people who go through these things. And we want you to know that you are part of this community. You're not alone. You don't have to go through these things alone. Help is available and out there. And we are happy to be part of this with you. And with that, we can move on. So September upcoming is National Suicide Prevention Month, so we're a few days early, but it's always a good time to talk about suicide, suicide and suicide prevention. Suicide has unfortunately become one of the leading causes of death for individuals of different age cohorts. It's a rising problem that's happened over time, and we see it in certainly a lot of different communities. My own experience, having worked with military personnel around suicide, it is always a tragedy. And so we just want to create resources and tools and make people aware. For those who follow SAMHSA and its work, you can always call or text 988 or the 988 Lifeline to get information or support for suicide and crisis. Can move on. A couple of housekeeping notes. As I mentioned, the webinar will be discussing suicide. Obviously, that can be upsetting for those, especially those who've lost somebody or somebody who's feeling desperate or feeling hopeless. We just want to make people aware that this is something we'll be discussing today. So to take care of yourself and whatever your needs are during this. The webinar is being recorded, and by being here, you consent to that. For questions, please feel free to put them in the chat. We will get to as many of them as humanly possible. And sound and video, so everyone is muted upon entry and the video is turned off. For technical assistance, please use the chat. As I said, we will have a lot of people here today. We're already up to 830. So it would be a little much to have everyone's microphones on or their videos on. The presentation materials will be sent to everyone who registered, as well as people will have a quicker access, I think, to the recording once it gets cleared and we've cleaned it up a bit. Otherwise, the final disclaimer is, of course, that the views expressed in this are not necessarily those of the U.S. Department of Health and Human Services. With that, we can move on. So for those of you who've been with us before, my name is Dr. Jeff Greenberg. I'm a clinical psychologist. I am the project director for the Eating Disorder Center of Excellence. And a lot of my work, of course, history has been things like certainly eating disorders, but of course also trauma work, working with military and veteran communities, head injury work, and a variety of different areas around rehab medicine, substance misuse, etc. I will now turn it over to my colleague and co-presenter, Dr. Doak.
Hi, everyone. My name is Jean Doak, and I too am a psychologist, and I am a subject matter expert within the Eating Disorder Center of Excellence in my work with Dr. Greenberg. And then I also am the clinical director at the University of North Carolina Center of Excellence for Eating Disorders. And I just wanted to provide a little bit of a shout out. I've been watching the chat, and everybody's been entering where they're from, and I very much appreciate the wide variety of locations that everybody is logging in from. And I've lived and worked and trained in some of these states, so that too is very exciting to see.
Absolutely. We're glad we have such a national representation.
Yes.
Our mission is to be the preeminent federal resource in eating disorders. We work to advance education and public awareness. We focus on prevention, treatment, and recovery. We do so through webinars, through peer-to-peer communities, and through tailored resources where we put a focus on early identification and prevention because we know that's where we can probably have the most impact. So I'm going to launch a quick poll. Basically, if people wouldn't mind answering which of the following statements are true. There is potentially more than one correct or accurate answer if people want to put that in. Yeah, the numbers are flying up. All right, we're going to move as well now. The next question, which is which of the following are you hoping to learn about today? All right, so we have a wide variety of areas. Um, So the two correct answers for the first question are that most people who consider suicide do not want to die, and that suicide is preventable. So we have a lot of correct answers there. Appreciate that. Okay. The results you can see. Great work, everybody. So let's get to today's topic and goals. The road ahead, we have four kind of points. Understanding the relationship between eating disorders and suicide, recognizing risk factors, determining when and how to intervene, and discussing resources for support. So we're going to talk for a minute about theory and practice around suicide. This is Joyner's interpersonal model of suicidality. Dr. Thomas Joyner is a professor at the at Florida State University. He's also considered the father of modern suicide prevention and suicide theory. I've actually had the privilege in my career of working with him. So he's an incredible, brilliant theorist and psychologist. So let's talk a little bit about his model description. Excuse me. Basically, Joyner's model looks at two concepts or two constructs: thwarted belongingness, which is essentially the desire to be part of something or to be part of the group, and feeling like you're being denied access to that, and then perceived burdensomeness, which is the idea that you feel like you may become a burden to others, or others will have to take care of you. But those two things alone are not really enough. And so we go over, as we look at the model diagram here, people have thwarted belongingness on the one hand, perceived burdensomeness, those two things. They have a desire for suicide, which means that they actually want to end their life. And then the last part is what we call capability for suicide. So the way to think about that is that even individuals who have desire to die by suicide, there's a survival instinct we all have. And you can see it if you've ever seen anybody up on a bridge or if you've ever seen anybody on a building. Even though they're thinking about dying by suicide, they actually clutch the bridge because that's kind of the normal human response. Overcoming that is where people are suddenly at very, very elevated risk. So if you've managed to overcome the fear of dying by suicide, want to die and then have these two elements of perceived burdensomeness and thwarted belongingness, that's where people are at very, very significant risk of dying by suicide. We can move on. So, what can providers do to take action to prevent suicide? Um, I always think that the first thing you can do when we talk about suicide prevention is where we start just in the limits of confidentiality. Obviously, this pertains to clinicians, but it's one of the first conversations we should absolutely have when we bring a new patient or client into a therapeutic environment. First things first, we want to do no harm. Discuss the limits of confidentiality. Obviously, those are when individuals may be at risk of harm to themselves or to others. I like to, when I see patients or when I've seen patients, go through and let them know what are the scenarios under which I might be required to actually break confidentiality, but always letting them know that I will never do that without speaking to them, never do that without a plan in place. Um, so there are three elements, there are several elements that we want to be able to talk about. We want to respect autonomy and create safety. So it's a bit of a balancing act because on the one hand, we want to respect the autonomy and individual ability to sort of make decisions for themselves, while on the other hand, balancing the need for safety for people. So there are a couple of tools you can use: connection, collaboration, and choice. Connection, of course, about the relationships we have with those individuals who may be at risk. Collaboration, working to make choices together, right? A lot of times people don't know what's available to them or how they could receive the additional help they may need. Most of the time we see people once a week. Um, and then choice, making those choices, allowing the individual or helping the individual to make the right choice for their own safety. Three R's: recognize, respond, and refer. And we should always be aware of resources that we have available to us for individuals who may be at risk. Specific action steps, as I said, discussing the limits of confidentiality, conducting risk assessments. There are a number of tools available for this, things like the Columbia Suicide Severity Scale. There are a couple of others. We'll go over those in a minute. Risk assessment is something that I always think of, and maybe that's because I historically have worked with communities that individuals may be at risk, individuals who have trauma, individuals who've been part of the criminal justice system, things like that. So I always kind of think about risk and risk appraisal as a function of clinical care that I've done. Creating a safety plan, right? Identifying warning signs, uh, identifying the internal coping strategies that people can use. If somebody's doing things like dialectical behavioral therapy, there are always tools to survive these crisis moments. Identifying social and supportive contacts who can help, can provide assistance, people you can turn to. Emergency resources, having check-ins with somebody during non-therapy hours, making sure somebody calls or they have a resource to call should their situation deteriorate, and then refer. Often we want to refer onto care to make sure that an individual is safe and in a place where they will do no harm so that you can continue the important work of helping a person to get better. Okay. The relationship between eating disorders. So amongst individuals with eating disorders, there's a strong correlation. Um, Eating disorders are often associated with poor self-esteem, self-hatred, and suicidality. Those with anorexia nervosa, bulimia nervosa, and binge eating disorder, well, they tend to be at the highest risk of suicide. From a comorbidity perspective, there was a high comorbidity between eating disorders and mood disorders. Of course, we know that people with mood disorders can be at risk of dying by suicide or engaging in self-harm. And individuals with eating disorders and elevated risk of suicidality, they can be difficult to treat and may require care in a secure environment. So in the past, we've talked about how individuals with eating disorders may be at medical risk because they may not be taking in enough nutrients, they may have electrolyte imbalances, things like that. But we also know that individuals can be at risk of self-harm, and so we want to make sure that they can be in environments when necessary where they can be safe to continue getting care. Um, Obviously, not everyone with an eating disorder will experience suicidal thoughts or behaviors or will engage in self-harm or ultimately attempt to die by suicide, but it is something that we should always be aware of. Okay, this is where I'm going to turn it. This is where I'm going to turn it over to my colleague, Dr. Doak, to get started on mood disorders and eating disorder comorbidity.
Thank you. So we're going to spend a bit of time talking about some of the facts and statistics and the co-occurring nature of these disorders. And so, as Dr. Greenberg was mentioning, there is a high correlation of eating disorders and mood disorders presenting concurrently. And this can dramatically and significantly impact all aspects of treatment, even access to treatment. And so, as far as the facts are concerned, we do know that about 54% of individuals with eating disorders also experience mood disorders, with major depressive disorder as being one of the primary co-occurring diagnoses. And what is interesting with that is that the presentation of an eating disorder and a mood disorder can have comparable and similar neurovegetative symptoms. For example, a decrease in appetite or a loss of appetite, sleep disturbances, low overall mood and energy. So sometimes it's a little bit difficult to tease out, but those can interplay together as well. And those overlapping symptoms can create a challenge for providers as far as diagnosis, assessment, and even identifying appropriate treatment referrals if necessary. And what creates the co-occurring cause would be several things. With eating disorders and with depressive disorders, we do know that there is dysregulation with serotonin, and so certainly that can impact mood and impact appetite. We also know that there could be hypothalamic pituitary adrenal impairments, which impact stress responses. So, lower tolerance to stress and distress in general. And then gray matter volume is impacted as well, where it becomes reduced. And oftentimes, what we see is brain fog, lower ability for concentration or sustained attention. Again, we can see that with eating disorders and we can see that with mood disorders. And then, as with many, many of the mental health disorders, there are all the genetic predispositions that come into play, but there's high heritability with both mood disorders and eating disorders. So it's something for us to keep in mind and to pay attention to. So this all leads us to what we see with patients whenever we're interfacing with them. And so we see with the co-occurring, there is often an increase in severity of symptomology, an increase in feelings of hopelessness, and decreased feelings of self-worth. And really significant as well is lower or poor emotional regulation, along with greater impulsivity or poor impulse control. And overall, with both co-occurring disorders, there's functional impairment in multiple domains of living. So it'd be work, home, school, etc. And then, as we've been talking about so far, there is a greater risk with both occurring of either non-fatal suicidal or self-injury behavior or suicidal ideation. So to have a better understanding of the co-occurring nature of anorexia nervosa and suicide, we'll go into a little bit more greater detail about how each create this presentation that is important for us to be mindful of. So individuals with anorexia nervosa, we know, are 2 to 9 times more likely to engage in non-fatal self-injurious behavior, which is remarkable, and that's something that we need to pay attention to clinically. Some of the factors that go along with that would be the impact of malnutrition and chronic restriction of nutritional intake, and how that can lead to changes in overall brain functioning, cognitive functioning, and then worsening mood related disorders and increasing vulnerability to suicidal ideation. 80% of individuals with anorexia who engage in non-fatal self-injury behaviors report that this occurred within the context of a major depressive disorder. So again, not only clinically do we want to be mindful of that, but we also want to ensure that we're assessing for the co-occurring possibility. Anytime we see an eating disorder, we want to assess for a mood disorder. Anytime we see a mood disorder, we also want to assess for an eating disorder and other potential co-occurring diagnoses. These comorbid co-occurring diagnoses include major depressive disorder, anxiety disorders, and substance use disorders. All of these have demonstrated an increase in the association of suicide attempts with individuals who have anorexia nervosa. Of note as well, this is interesting information that has come on board with research over the last 15 to 20 years, is that individuals with anorexia nervosa are also 15 times more likely to have a diagnosis of autism spectrum disorder, 2.5 more times likely to have an anxiety disorder, and 9 times more likely to have a diagnosis of obsessive compulsive disorder. And individuals who experience anorexia nervosa are 25 to 33% more likely to have thought about suicide. So these numbers and statistics are staggering and create pause enough for us to have a webinar like this to increase information and awareness around the co-occurring nature of these. So we talked about cognitive impairments or the impact on brain functioning. And so we're going to dive in a little bit in more detail and talk about the structural impacts and the functional impacts. As far as the structural impacts, what we do know from malnutrition, and more specifically with anorexia nervosa, or any eating disorder that has a significant amount of weight loss leading to being undernourished or malnourishment, is that there can be a loss of gray and white matter. And these are the things or the components of the structures of the brain that are most related to emotion regulation, decision making, around impulse control, and self-perception. And what we do know from MRI studies is that individuals with anorexia also experience brain atrophy. And the research is inconclusive as to whether or not someone who recovers from anorexia actually recovers their overall brain functioning. So a return to the structural functioning of the brain as well. And then the dysregulation, there are hunger and stress hormones related to this. And so malnutrition alters those levels as well. And that as well impacts emotional regulation and increases the vulnerability to a co-occurring mood disorder. With regard to the functional impacts, this happens more often than not than what we see with students, for example, adolescents and young adults, is that they often talk about brain fog and not being as quick as they used to be. For example, decreased attention, poor sustainability with attention and focus, and oftentimes reporting this need to have to work harder to get the same results that they used to academically. So that's important to note. Usually we do see a return to normal functioning with renourishment and recovery of the eating disorder. There's also some brain instability, and this again is related to poor emotional regulation, increase of irritability and impulsivity, as well as mood swings. And within the context of overall functional impairments, we also know that there could be some decreased self-awareness and decreased in an ability to see and experience themselves accurately. So some distortion, which is a clinical term with regard to that. And within that context, there's also an added layer of a difficulty in being able to understand and recognize and appreciate how severe the eating disorder condition might be. So let's talk about what our responsibility is within this context. And this is a collective responsibility. We all share it, and we need to make sure we don't have a diffusion of responsibility. So as far as behavioral health clinicians are concerned, as Dr. Greenberg was mentioning earlier, routine screening is going to be key. Early and often is often what we recommend. We know that mood states are not static disorders. Eating disorders are not static disorders. Therefore, the impact on mood is not going to be static as well. It's important that we let our patients know well early on into our relationship with them that the screening is a normative process of the treatment experience and that it's going to happen often. And the primary goal and reason for that is to work collaboratively to ensure safety. With primary care clinicians, it's the same type of mantra as far as screening is concerned. Here, there might be an added component of maybe determining if there's a need for involuntary hospitalization, if there's acute suicidality and high risk involved. And then this would also be an opportunity to work with an integrated team if possible. Certainly with a collaborative care model would be of great assistance in navigating the care system. And then suicide prevention specialists. Here we can talk about the development and implementation of suicide prevention using public health and safety approaches. And I have a little anecdote actually related to this. Over the summer, I was traveling in upstate New York, and in this one area where we were traveling, we were about to go over this really long, tall bridge. And I noticed that on both sides of the bridge, there was a 988 suicide prevention sign that was on either side. And there was messaging that said, "You are not alone." And it was the first time I saw something like this. So I think this is an example of the public health and safety approaches that can be taken. As well as with all of us taking on this collective responsibility, we know that oftentimes these types of situations can present in the school setting. So school-based personnel can be armed with screening and identifying resources and support for students who are at risk for suicidal behavior and ideation. And then our greater community. So we always want to check in on friends, families, and colleagues without any judgment at all, reducing the stigma and reminding everybody that they're not alone. So our understanding and advocacy is vital and critical in addressing the risk of suicide with patients with eating disorders and any co-occurring disorder as well. So we're going to review some eating disorders and suicide statistics. So up to 33% of individuals with eating disorders report engaging in non-fatal self-injury at some point during the course of their treatment. And we've talked about this in a few of our webinars beforehand. If you had the ability to participate in those, this is a familiar statistic to you, but it's important to note that anorexia has the second highest mortality rate of any other mental health illness. And that indicates that around 5 deaths per 1,000 person a year occurs with anorexia nervosa. And this is a second highest mortality rate only behind opioid use disorder. So this is greater than major depressive disorder, greater than PTSD, greater than many of the other mental health disorders. And individuals with anorexia nervosa are 18 times more likely to die by suicide. And those struggling with bulimia nervosa are 7 times more likely to die by suicide. And approximately a quarter to a third of people with anorexia nervosa and bulimia nervosa have engaged in non-fatal self-injurious behavior. And I think this is an important slide to pause on just for a little bit, because if we don't ask, individuals are less likely to tell. So this is the important take-home note that just because we ask is not going to incite the behavior. Asking demonstrates and conveys that we are committed to ensuring and working toward the safety and welfare of their care.
One of the things we should note is that, and this came up as a question that somebody asked, which I think is a really good question. They had asked about when we talk about non-fatal self-injurious behavior, are we talking about the same thing as when people hurt themselves? Sometimes you might see in people with history of cutting behavior, things like that, more related to personality disorders or things of that nature. We're really talking about people who, to one degree or another, are seeking or trying to end their lives, but the intensity of the act may not be as severe, and so the damage may not be as severe. But we are talking about individuals who are certainly at risk, and we want to keep that in our minds.
I'm glad that question came up, and Jeff, I appreciate that differentiation. And so sometimes the non-fatal suicidal behavior can be confused with non-suicidal self-injurious behavior. Both are risky and both are worthy of asking our patients and clients about. But the non-fatal suicidal behavior is the area that we're focusing on today.
Okay. So we want to understand warning signs and risk factors. Um, when we talk about warning signs and risk factors, I don't have to read these all off, but we see people basically withdrawing, being isolated, people who are talking more about things like feeling isolated, people whose mood vacillates, more so than usual. Uh, When I was in training a long, long time ago, one of the things we used to talk about was how behavioral health was really about a lot more or less of something. So, we talk about people who may be depressed, we talk about people who may be sleeping too much or sleeping too little. We would be talking about people whose moods are fluctuating more than usual. And those are the kinds of things we really want to be looking out for. People who are talking about death and dying. It's not unusual for people to sort of colloquially make statements about that. We'd start to become more concerned when those statements seem to be more reflective of their actual intent or not a dark joke or something like that. One of the things that actually is incredibly interesting is that for individuals who are at very, very high risk of suicide, and you can actually see this if you look at some of the work of Dr. Joyner, there's a reduced eye blink rate. We don't know why that is. It's likely a neurological phenomenon, but individuals at high risk of dying by suicide just do not blink. Um, for individual risk factors, we're talking about substance misuse or increased substance misuse, family history of suicide. Family history of suicide automatically increases the risk of suicide for other members of the family, especially first connection or first order family members. Difficulty regulating emotions. Again, this is more so than usual. For those of you who have or work with adolescents, you know that's a normal thing, the ability to regulate their emotions. We're looking at more so when somebody's at risk. Engaging in self-harm, treatment history, chronic pain, hospitalization, especially for serious problems, tolerance for high risk and impulsive behaviors, and really sort of these complex case conceptualizations of multiple psychiatric disorders, substance misuse, and other conditions, as well as, of course, financial problems. People feel like they are feeling hopeless or that they can't be helped. So when we think about the interconnectedness, and this is why whenever I talk about these things, I kind of say it's intensity, duration, and type, because so much of behavioral health looks like other elements of behavioral health in many ways, right? So like emotion dysregulation is something we see in actually quite a few conditions. So for suicide symptoms, we talk about, people who may be taking dangerous risks, thinking or talking about or posting about death or violence, and displaying extreme mood swings. For eating disorders, we're talking about, people who are very fixated on food, weight, or being in shape. This is more so than usual. Again, we sometimes think about maybe an athlete who's, very focused on being in good physical shape to play a sport. right? This is where it gets to a level that's likely either over the top, unhealthy, overly fixated, that sort of thing. When people are doing things like eating in secret or hiding food, when people are excessive or compulsive exercisers, it's one thing to, get 30 minutes of exercise a day, which, I wish I could say I always had the time to do or remember to do. And it's quite another to get up at like 2 o'clock in the morning so you can work the exercise bike or the running machine for 2 hours while everyone's sleeping because you probably shouldn't be doing that. And then when we talk about the overlap, we've got, classically symptoms like low self-esteem and self-doubt, self-hatred or loathing. And then, of course, the perceived burdensomeness and thwarted belongingness. Um, as Dr. Doak had said earlier, suicide ideation affects approximately 25 to 33% of individuals with anorexia nervosa, bulimia nervosa, or binge eating disorder. Those are, pretty shocking statistics when we think about it. So when we think about risk factors and protective factors, at the individual level, risk factors and protective factors, things like other mental health conditions or substance use, not having those other elements can be helpful. Family conflict, experience with suicide, sort of loss of either friends or family, social isolation, community violence, if you live in an area where violence is endemic or, in the midst of war zones or things like that, and societal level factors, right, where people may feel stigma or may experience bigotry or discrimination. And then when we talk about protective factors, we talk about individual level protective factors like being a really effective problem solver. I actually was fortunate to do work with the FSU team. And what we essentially found was that across samples, people who were really effective problem solvers did not, on average, die by suicide. They might engage in some harmful behavior, but they were very unlikely to die by suicide. Relationship levels, having supports in your life, being connected to others, having a healthy community to be part of, whether that's a team or a school group or a church group or whatever that may be, having these supportive and positive factors around you. And then societal level factors, right? Feeling part of things, not experiencing, discrimination or bigotry, feeling connected and part of things. Those are the things that really do go and protect us. That doesn't mean that, of course, you're at zero risk if, one way or the other, or at absolute risk, but these are the things we generally find are, sort of buffers or abrasives to our overall risk level. So it's important to screen for suicide risk. I talked about this a little bit earlier. So early identification is absolutely important. Prevention and guiding treatment decisions is something that's absolutely critical when we talk about sort of being prepared in terms of knowing the individuals you work with and whether or not they are potentially at risk. When we talk about suicide screeners, right? Typical screening questions, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? This is the this is the ask questionnaire. There's also the Columbia Suicide Severity Scale, and of course the PHQ-9 has questions about suicide. These days, it's actually usually part of any time you go to a physician's office. They ask those questions. Um, Anytime somebody mentions one of those things, this is where we do not tolerate any level of risk. So if somebody is acknowledging that they are at risk across any of these questions, we absolutely want to take action. We don't want to downplay it. We don't want to minimize it. This is important. It's what we do in terms of being clinicians, or if we're not clinicians, these are the things we worry about and connect with as parents, as friends, or people who have any other types of relationships with these individuals. So again, a yes to any of the questions is something to take very seriously. And you can see basically that, a yes should lead to certain actions. That could be a safety plan or rediscussing or revitalizing a safety plan. It could be about making a determination for a higher level of care. And these are the things we really want to make sure that we're comfortable with as we move to working with individuals who have who can be at risk. If you're in the field of behavioral health, this is stuff you have to in some way or another be thinking about, because this is sort of par for the course in terms of the work that we do. All right, Jean, if you want to
Mhm.
jump in, let me know when to jump back.
Yeah. So the next few slides, we're going to review risk of suicide within the context of eating disorder treatment and their interrelatedness. And so, similar to what Dr. Greenberg was talking about with suicide and screening earlier, we always recommend that for an eating disorder as well. And so, where somebody lands in their risk level may determine course of action, immediate next steps, and what their treatment plan might look like. And although it may be obvious, it might be worthwhile for us to spend a little bit of time talking about the differentiation between the risk levels as well. So we'll start on the left with the high risk. And so if a patient is at immediate risk for suicide, you are going to be considering higher level of care. You're going to follow the guidelines with regard to that. And ideally, you want to provide as much support, safety, and security as possible in the least restrictive environment possible. And sometimes that intersection works really nicely as far as the care that's available and accessible, and sometimes it doesn't. So this is where clinical judgment may have to come into play as well. But the overarching priority is maintaining safety. And that should be what is communicated to the patient as well. I don't think any patient would want to be admitted into an inpatient unit. However, with the emphasis on safety, that may be the environment that they need to navigate that part of being at high risk. With medium risk, you have a little bit more flexibility in decision making. Again, you still want to incorporate issues of deference, autonomy, individualized treatment planning, etc. But safety planning will be at the core of all of that. And clinical care for an eating disorder can be implemented as well. When somebody's at high risk for suicide, that may be the primary treatment course. And so they may be admitted for stabilization of that in an inpatient treatment center or treatment level of care before being able to engage in eating disorder treatment. There are a few places across the country that can serve both levels of acuity simultaneously, the eating disorder and suicidality, but not every treatment facility has that capacity. So again, you're identifying what is the greatest risk imminently for the patient in this moment. Suicidality will trump eating disorder treatment more often than not. And then as far as low risk, you have even more flexibility here. So you'll want to continue to assess for risk of self-harm, and then you'll talk about goals, treatment goals, safety planning as well. And then the clinical care for the eating disorder can be implemented with minimal intervention around suicidal ideation or suicidal behavior. Again, that changes with risk level. And then throughout the course of treatment, you're going to be monitoring risk. I think many people are familiar in working in the behavioral health realm in working with individuals who have major depression. And so it is very common to be attuned to whenever individuals start feeling better mood-wise, that might also coincide when they might be at higher risk for suicidal behaviors because they have a little bit more energy, they are less fatigued, etc. And so the same holds true with an eating disorder. And so screening for risk should be not only at the beginning of treatment, but throughout the course of treatment. So let's talk about preparing our patients for care at these various risk levels. So again, starting from left to right, in the high risk category, we're going to express concern for individual safety. And we will reiterate that that is the primary driver for any treatment planning, any next steps that we'll be taking is to ensure safety and as much as possible to work collaboratively with the patient. We'll discuss what level of care is needed to ensure that safety, and then collaboratively work on incorporating support systems, individuals, care communities, etc. Continue to work on developing a safety plan, maybe even expand the safety plan and implement that safety plan within an inpatient treatment, even if it's involuntary as well. With medium risk, again, we're still reiterating that primary concern for safety. That doesn't change. That is always the driver force. And then here you might have multiple options for care within the context of higher level of care. There could be an opportunity to discuss pros and cons of partial hospitalization versus intensive outpatient treatment versus residential. You have a little bit more flexibility with a medium risk. And if needed, you can always implement an inpatient plan for their care. And then again, implement the commitment to a call around including support individuals, support systems, and implementing them in a proactive way. And with the low risk, again, you still are using safety as the driving force, but you have a wealth of treatment options available to you. And ensuring immediate safety is not the primary concern here. So, in that regard, you still want to continue to develop safety plans. You review those safety plans periodically. And even though they're at low risk, and I'll go back and say even at medium risk, you're going to continue to screen throughout the course of their treatment to ensure that you're keeping an eye on any immediate issues of danger or risk that might pop up during the course of treatment. So the next few slides are going to be some patient scenarios, and I think I might transition to Jeff to go through the scenario, and then he and I can talk about the results of the scenario of each of the scenarios.
So, thank you. One of the things we're going to be doing, as Dr. Doak had said, is we will be presenting a couple of scenarios. What we'd like you to do is, if you can, put into the chat whether or not you think these individuals are at high, medium, or low risk. So first up, we have David, a 33-year-old man with a family history of mental health disorders, diagnosed with anorexia nervosa a year ago and OCD 5 years ago. Over the past year, he's begun to run excessively, eliminate foods, and create full food rules, leading to his anorexia nervosa diagnosis. He's been admitted to inpatient care in the past year, twice, and both times he gained enough weight for discharge, but inevitably relapsed. So his presenting concerns are that he reports increasing feelings of hopelessness over the past month, and mentions feeling guilty after eating certain foods and feeling a burden to his family and friends. David's clinician finds that David is engaging in more risk behaviors such as drinking more alcohol. Okay, and we're going through, yeah. I think a lot of people are getting this, are very, very correctly looking at this individual as having pretty significant risk. This is an individual who's at medium risk, but it could be medium to high for those of you who put high, because there's certainly a lot of risk factors. He's been diagnosed in the past with an eating disorder and admitted to primary care. Excuse me. He's showing signs of behavior which are concerning, but do not specifically constitute self-harm. So he hasn't been engaging specifically in something that we would consider as out and out self-harmful. His therapist should discuss these concerns and develop safety plans around potential for inpatient care. Obviously, the risk of alcohol use is concerning. It lowers inhibition. It makes individuals certainly more at risk for a variety of negative outcomes, not the least of which certainly is drinking and then operating a car or other vehicle or other type of vehicle where somebody could get hurt. And then you want to make sure that you're regularly monitoring the individual to be prepared to initiate the agreed upon safety plan. Good work.
And I was
All right.
going to add as well, if I may, I think anytime that you may be on the fence about risk level, and that may have an implication on either what your safety plan will include or your treatment plan, there's always that opportunity to get consultation from a colleague as well and rely on your screeners that you use. Sometimes it's just a little helpful to have an additional perspective of that. And we can see that in the chat. Some people said medium risk, some said high. So this is a great opportunity and a great scenario of really teasing out what the potential implications would be for treatment and safety planning.
Absolutely. Okay, let's move to this scenario 2. This is Harper, 25-year-old female, diagnosed with anxiety and polycystic ovary syndrome 4 years ago. She visits her primary care doc for annual physical and a recent difficulty concentrating in work and general disinterest in activities. She has recent abdominal pain, and since her last clinical assessment, she's lost 30 pounds with no sort of underlying health causes, but is within normal body mass index. All right, we're getting answers in. All right, I think we can move to the next. Most people are responding to this. Yeah, this is somebody at generally lower risk. Um, the gastrointestinal issues and other challenges are certainly something to be of concern about, but they're co-occurring often with eating disorders. She may be showing signs of bulimia, but we don't have an out-and-out diagnosis. We definitely want to find out why she lost 30 pounds. Was this a goal or something that she was trying to do? A comprehensive evaluation, including assessment for eating disorders, is absolutely warranted. Individuals like Harper benefit from an evaluation to identify a full clinical picture. You know, I often find that the only times you see an individual who just has anxiety or just has depression or just has, right, is in a clinical case vignette book. I have never clinically seen anybody who's just that neat, cut and dry. And so I love to do a comprehensive evaluation on individuals because I like to know what's really, really happening with them so that their care can be targeted to the very things that they're experiencing. We can move on. So number 3, this is somebody who was diagnosed, Alex, who was diagnosed with anorexia 3 years ago, past history of significant non-fatal self-injury. She's disclosing current self-harm, including recent notable self-administered cigarette burns. She visits her primary care doc for annual physical and discusses the current thoughts of ending it all. The clinician finds that Alex's BMI has continued to drop. She's using new substances, including a GLP-1 or the new medications that are helping people lose weight. Okay, we've already got people responding. Yeah, 100%. Let's move on to the next slide. Yes, this is somebody at very significant risk. Anytime somebody tells you they're thinking of ending their life is something you should absolutely take seriously. A history of non-fatal self-injury and ongoing eating disorder diagnosis, especially serious things, somebody who's burning themselves with cigarettes, that is a pretty exaggerated and significant response in terms of distress. We would want to actually consider this individual potentially for inpatient care. That may be the safest environment for them until they can kind of learn how to better manage some of their distress. Next. All right, we have some resources for support. Um, basically want to go through and kind of talk about encouraging treatment is key. We don't want to, forcing treatment upon people can be very difficult, but we really want people to be encouraged to get the help that they need. Minimizing risk. Now, this may mean things like removing means of death. Sometimes people will do things like if they are a firearm owner, they may ask somebody to hold on to their firearms for them until they are at a lower level of risk. Or we may seek to get things like certain medications out of the house, that sort of thing. It's important to note that the path to healing takes time. People do not immediately recover from these things. There's work to be done, and it's hard work, admittedly. Long-term survival is common, although when we work with people with these various types of difficulties, we know the risks that they have, and we worry about them. I certainly can remember having great deals of worry for the people that have treated over the years. But it's also important to know that the majority of individuals will not only not die by self injury, that most people won't actually significantly attempt to die by self injury or engage in non fatal behavior. So realistically, what we want is we want to know that the odds are in the favor for people to live as long as we are providing the right types of care, resources, and support. So open communication and increased connection, those are critical to people, as we know, thwart a belongingness, perceived burdensomeness. And it's always important to note that full recovery is not only possible, but we would do better, I think, to start to expect it more. We want our people that we work with to thrive. And the more we put into that, I think the better overall it can hopefully be. Safety plans. I want to give a plug to SAMHSA's 988 Suicide and Crisis Lifeline, of course. Um, Basically, we want to go through, if you think about, we want to identify what are the warning signs, what are coping strategies, who or what can people turn to, including yourself as clinician? Who can you ask for help, right? Make sure that these individuals have these resources at their disposal. What are the professionals or agencies you can contact during a crisis? Right? That could be everything from 988 to 911 in case somebody is feeling really at risk. And write out a plan to make your environment safer. For example, again, perhaps getting a weapon out of the house or having somebody hold on to a medication which could be used for self-harm, that sort of thing. Next. Okay, 988 Services and Care, again, giving another plug to the 988 crisis line. This is something that has a lot of resource for individuals who may be at risk. I cannot overstate how important it is and how much we recommend people have this as a resource to engage with. All right. We uh, we went a little long, so I'm going to head through the recap of lessons learned. We'll do a Q&A. For anyone who can hang on, we're happy to do more of a Q&A, but I understand if people do have to go. So lessons learned, eating disorders and suicide, they're deeply interconnected. You probably can't disentangle them. Warning signs and risk factors are important to know, and they overlap with other conditions, so we should generally be aware of them. Suicide risk should guide eating disorder treatment. We always want to make sure that we are focused on safety. That is the paramount thing with anybody we provide care for. Reducing shame and promoting open communication saves lives. Remember, if feeling disconnected and feeling a burden are the things that place individuals at risk, the opposite are things that can help people avoid that risk. So we want to continue to make people feel more a part of something and less burdensome. Okay, here are some references people can use. Everyone will get these. And now, for anyone who can hang around, we're happy to do a little Q&A.
Jeff, there were a couple of questions that were posted in Q&A that we might be able to quickly answer. And this is in no particular order. Someone asked about a patient having SI and an eating disorder. Does being admitted to an inpatient unit for SI place the eating disorder at risk? So there are very few treatment centers, for example, who have the capacity to treat both at the same time. And so we know that as long as they're in a structured environment, there is the potential of getting some nutrition or nutritional rehabilitation on board as they're working toward um, navigating the suicidal ideation. There are times in which someone might be recommended to transition or transfer to a residential treatment center for mood-related disorders. And many of those don't have the capacity to adequately treat the eating disorder. And that's where oftentimes there is a reach out to try to find a different treatment facility that can target both mood and eating disorders. So there aren't many across the country. I just want to acknowledge that. And even fewer that would take Medicaid or Medicare. So it is a challenging intersection of co-occurring diagnoses.
Great, thank you. We have a person who was asking about the differentiating between non-suicidal self-injury and non-fatal self-injury, whether the difference is intention or the manner of self-harm. It really is more about intention. Individuals who engage in non-fatal suicidal self-injury, there is a goal to end their life. They just don't, it does not happen for a variety of reasons. Whereas other self-injurious behavior, for example, things like cutting without the intent to die, burning oneself, those types of things, those are very, very concerning and absolutely indicative of some pretty significant pathology, but are certainly things that we would want to, but are certainly a little bit different than suicidal behaviors. Let's see, we've got, at what point do we consider eating disorders or change in eating necessary to breach the limits of confidentiality? Good question. Again, we have to remember about the limits of confidentiality, right? This is about harm to self or others. So the mere presence of an eating disorder is certainly not specifically a reason to breach confidentiality. It is, of course, very wise to ask people to, let people in their lives know what's happening with them. Again, they're feeling, they're disconnected or maybe feel disconnected. They may feel like a burden, but actually unburdening themselves to family members or friends to get support and to be part of something is an important element. But it's not the specific act of having or experiencing an eating disorder. We really want to be thinking in terms of safety from a confidentiality standpoint. Maybe do one more. Uh, yeah. Mm, oh, I'm now getting a lot of. Um, Here's a question. Can long-term sustained self-destructive behavior be a sign of suicidality in slow motion? Well, that's a good question. I mean, self-destructive behavior can mean a lot of different things. There are people who sort of get in their own way as a habit of doing things like damaging themselves at work or in relationships. Really, I think what we want to talk about when we think about suicidality is the elements for a person that are really around true danger to self, right? So it's not necessarily about, oh, I never do a relationship right, or I never, I always screw it up after the third date, or something like that. Really, we're talking more about self-destructive behavior that's truly harmful to the self, right? This could be, I mean, certainly eating disorder-based behavior is self-destructive because it's, by nature, not healthy behavior. But we'd be talking about people who are doing things like using substances, increasing their use of significant substances, drinking more alcohol, those types of things. Suicide or risk appraisal of suicide is just something that the way I was always taught and the way I've always practiced is that it should always be something kind of in the back of your mind, when you're working with individuals, there should be the little alarm bells or the spidey sense that goes off when you're concerned about somebody. Because if you're feeling concerned for them, there's probably a good reason that you feel that way. And at minimum, we know there is no harm to asking. It does not increase somebody's risk. You are not going to talk somebody into dying by suicide. Conversely, what you are going to do is inform an individual that you care enough to check in on them and see how they are doing. I think we'll end there. I do want to thank my colleague, Dr. Doak, for presenting with me again today. Another great presentation. We thank everyone. We had more than 1,000 people here today, which is really impressive.